you mentioned that if we could eradicate this disease, that would be great. And that 50 years, 100 years from now, this disease ceases to exist or it exists only in the background. That's cheaper for your successors. But that doesn't answer your question today. So can you see a way to so structure payments, maybe it can't be an individual company, maybe it has to be a consortium or the government, to say, look, this is worth investing in. How do you do that?
I don't know how you do that. I will say, we all want the same goal. I mean, we want cure, we want eradication. We're not, you know, the challenge is, you know, you got to look at the end user, whether it's the patient or the employer group or the health plan. It's still their money, and they still have a financial responsibility to manage the money so that medications are affordable for everybody. It's not just HIV. It's cancer. It's all the orphan drugs. It's inflammatory disease, so multiple sclerosis. So we all have the same goal. We're all moving in that direction. We don't want to stand in the way of that. But at the same time, I can't go back to an employer group and say, your premiums just doubled next year because what we're doing in this area. That, you know, there's some issues with that.
Well, then, if you can't go to the employer and say your premiums have just doubled, and yet it is the best thing for society. What do you do?
Yeah.
You've got a tough job. I never thought I'd say this to him. You've got a really tough job.
Yeah, the unfortunate reality is that employer is probably going to say, not my. I'm going to take my business and go to the payer down the street that has a lower premium that's not doing this program.
And then, if that's the case, and if the treatment that employer's employees are getting is not only less effective for those employees, but for their families and for their associates, that employer is going to have an economic hit. Can you sell that?
It's hard.
Hard.
You know, when I was a medical student in the 80s, many years ago, I worked in an STD clinic in Baltimore as a medical student. And the treatment for chlamydia was tetracycline, QID, on an empty stomach, 4 times a day for a week. So 28 pills, one pill 4 times a day on an empty stomach. And it was cheap. It was dirt cheap, pennies. But I think at some point they had to realize that a more expensive treatment, doxycycline, was simpler and more people would take it and less people would fail their initial therapy. And even though it might be a little bit more cost intensive on the front end, on the back end you'd have more success. And now, of course, you know, we give a single dose of azithromycin to treat chlamydia. Because even though tetracycline would be still much, much cheaper, I think at the end of the day, you have more success with a better regimen. And I think that's where we are with HIV therapies. There may be cheaper ones that are out there, but in my mind, the cheaper ones that are out there today are not necessarily the ones that are going to be the most successful.
Well, I think payers should be more involved. We want to be more involved. The challenge is right now, whenever we get involved, we're kind of framed as the evil empire, and we're just doing things for cost, and that's not the case. And so a lot of it is hands off. I would like to see a pivot. I would like to see more collaboration, and having this conversation about are there ways that we can do a better job proactively of screening, of being more involved in care management and all of these things, spending the money to do that. But at the same time, if I can't do that without having a conversation with the providers and the pharmaceutical companies and how I can save money, it's one-sided.
But Jeff, I think if you followed the DHHS guidelines, I think that we would be, in concert with each other. And I think the DHHS guidelines are good in that respect.
So there's the question. We can dig into that. So we have 4 preferred regimens. They're all integration inhibitor based. So
recommended. That's the word now.
So we have 4, one? Right? Let's say there's a couple manufacturers. One is, 2 of them are single tablet regimens. The other 2 are two tablet combos. If I go to you and say, manufacturer X is giving me a better price to pick this one, are you going to allow me within those 4 to say, initially start with that one, and then after that go wherever you want, but help me do that because then I can get a better price on that drug? Is that something we can have a conversation about?
We could, but also, let's take that. So of the 4 recommended integrase inhibitors, one of them has a booster. So it has a drug that inhibits the cytochrome P450 system and has a myriad of drug-drug interactions. One of them has a high genetic barrier to resistance. 2 of them have a relatively low genetic barrier to resistance. And so now all of a sudden things get a little bit more interesting. What if you choose the one that's cheaper, but it has a lower genetic barrier to resistance and more drug-drug interactions and more side effects?
And there's,
So-
there's the crux.
Okay, but if you have a valid clinical rationale why your patient cannot be started on his preferred agent, then you have an exception to,
But for the
process.
80-90% that fits, let's allow me to do that.
So for the ones that you can prescribe his preferred
But see,
medication,
that's the challenge.
then
Whenever we have these conversations, it's like, you can't do that.
Well,
And
no,
then we're like,
I think.
no, but I'm saying,
well, I think.
what we get beat up on is you can't do
But
that.
I think we need to educate providers that there is an exception process. It's not a one-size-fits-all approach, and I think that's the miss.